So Dr. Shweta Saurasia, she will be presenting on developing and implementing CVI assessment and rehabilitative toolkit.
Thank you, judges. Cerebral visual impairment manifesting as complex visual deficits poses unique challenge. Standard of care includes neurological intervention with limited emphasis on visual rehabilitation. Recognizing this gap, we introduced a toolkit to address the diverse manifestations of CVI. So the objective of the study was to describe the process of development and implementation of a toolkit for assessment and improvement of functional vision of children with cerebral visual impairment. Methodologies consisted of systematic and structured approach in 4 phases, including a prospective pilot RCT after CTI registration. Initial survey consisted of conducting research, comprehending problems, defining objectives. Phase 2 consisted of identification of the core component, exploring the domains of assessment, brainstorming the ideas for the toolkit and the rehabilitation strategies, prototyping and revision of the tool design. Phase 3 consisted of validation of the toolkit and pilot testing of the randomized controls trial. Phase 4 consisted of user feedback and toolkit refinement. In the methodology, the RCT consisted of 2 groups. Group 1 consisted of children with CVI receiving visual therapy kit, and Group 2 consisted of children receiving standard of care, and the study period was 1 year. Children 6 months to 5 years diagnosed with CVI were included, and patients of debilitating disease and organic pathologies were excluded. With a 80% power study, 25 patients in each group were selected. After the screening and enrollment, the randomization sequence was generated by the computer-generated method. The clinician doing the allocation was blinded from the examination. The baseline evaluation included history, CVI questionnaire, neuro-ophthalmic profile, neurovisual behavior profile. Follow-up was done at the end of 1 year, and the patient underwent neurovisual behavior assessment or the functional scores. The final toolkit we named as the OptiSync Rehab Assess Toolkit. The toolkit was implemented and tested by the RCT, and the improvement in the functional vision or the NVB score in the intervention group was compared to the control. As the name suggests, that the toolkit had 2 components: the assessment scale, which was NVB scale, which was for the comprehensive assessment of various domains and profiling, and the rehabilitation tools, which address the specific neurovisual behavior and functional component, functional vision scoring needs. The NVB score had 4 domains: visual attention, visual motor, visual communication, and visual processing, and along with the 57 items. It comprised simple and complex visual tasks and skills based on characteristic feature profile, which was dorsal and ventral stream. The rehabilitation toolkit comprised basic visual stimulation program, complex visual motor skills, simple motor task, and visual perception skills. Rehabilitative stimulation program had light therapy for the visual stimulation. The light-based exercises had light chamber for the visual stimulation, visual motor skills, and visual perception, and digital visual stimulation program was for the visual stimulation and visual perception. The light chamber was focused on the stimulation for attention. It was integrated with tactile stimulation, and visual motor integration was done for the hand-eye coordination. The visual processing included tasks for the size discrimination, visual search task, task with the visual clutter, visual discrimination and peg puzzles, and visual recognition tasks. These are some of the videos of the home exercises done by the children with the toolkit. Non-light rehabilitative exercises were done with the color and with the movement. The implementation was done with studying the change in the NVB score between 2 assessments in the RCT. Wilcoxon sign test was used to see the change between groups, and Mann-Whitney test was to see the change between the 2 groups. In clinical profile, birth asphyxia was the primary etiology. We did the neuro-ophthalmic, oculomotor, and CVI profiling. Coming to the baseline assessment results of the first assessment, the mean age in the control was 2.35, and in the intervention group it was 2.9, and the difference was not statistically significant. The baseline visual functions in the first assessment, the difference in the 2 groups was not statistically significant. These are the scores in the control and visual therapy group of the different domains, and the difference was not statistically significant at first assessment. At the end of second assessment, there was statistically significant difference in the functional vision score after 1 year. And among other visual function, attention span, there was statistically significant difference between the 2 groups. There was also statistically significant positive correlation between various domains. Coming to the discussion, OptiFlow Rehab Assess Toolkit, there is a multidimensional approach, a tailored function visual assessment protocol for various domains of CVI, target therapy catering to the visual needs by understanding the most affected domain. This study signifies the role of rehabilitative visual therapy having significant improvement in functional vision. Eliminov et al. Used the visual attention and visual communication skill, but our study had visuomotor, additional visuomotor and visual processing domain. The novelty was the first study to design a neurovisual behavior assessment scale on various domains, first study to design a rehabilitative program with toolkit, and the first study to evaluate rehabilitative toolkit via a pilot RCT. Strength of the study was RCT. So to conclude, this initiative integrates technological integrated practices and a nuanced understanding of CVI, aiming to assess various domains and transform visual rehabilitation for affected children. Thank you.
Thank you. Thank you, Dr. Sweta.